We had just finished building this house and moved in, and I had been having what I thought were just GI issues, and so I had pushed my doctor that I need to have a colonoscopy and was very shocked at the diagnosis.
I remember the phone call. It was a Friday morning. It was Beth on the other end saying, "I've got colon cancer." You're in shock and disbelief, and she's only 31. This is something that they don't even check for until you're in your 50s.
Everything else fades away, and nothing else is important other than making sure you're still here for your family and for your kids.
When I initially met Beth, she was very anxious. She was afraid of what the future holds. She had a small kid. She was planning for another kid. Colon cancer in the young behaves differently. They're often very aggressive. After we do surgery and cut the cancer out, we often treat them with chemotherapy-based treatments for an average of 6 months duration.
Chemo was hard from my very first session. The neuropathy was the hardest thing. You can't drink anything cold, you can't touch anything. It was the middle of winter, so going outside was really difficult. I actually wasn't sure if I'd be able to finish all of it because of the adverse side effects.
We don't know if all patients require 6 months of treatment, but the challenge is we don't have good tools to decide which patients require full 6 months, which patients we could stop sooner than that. The standard tools that we use for monitoring, such as the CEA in the blood or imaging such as CAT scans, they're good to a certain extent, but there has to be a sufficient amount of tumor activity for it to pick up. We needed something more precise, and that's when I decided to utilize Signatera. Looking at a blood test where we are able to isolate DNA fragments from the tumor cells helps us figure out if it may be safe to stop or de-escalate chemotherapy. When we did the Signatera testing at 4 months of chemotherapy, it did come back negative.
As soon as it came back negative, that's when I really felt like, okay, I really am done with chemo. Maybe we can start trying to have a baby sooner.
We had to make a choice with the best and most accurate information we had, and we felt that Signatera provided that for us to, at that time, make the decision to try to conceive and try to expand our family.
Once we found out we were pregnant, we talked about how are we going to monitor for cancer recurrence. Dr. Kasi said, we're not going to be able to do CTs, but we have your Signatera test that is going to pick up any remaining cancer if it occurs while you're pregnant. Signatera did give me the peace of mind while I was pregnant because there was no other indicator for me that I'm healthy, this baby's going to be healthy.
So far, we have not seen any evidence of recurrence of cancer. Hopefully, the cancer never comes back and she's cured.
Signatera gave me the freedom to just feel that everything is going to be okay. I am healthy again, and we can actually move on, just enjoying being together.
Welcome to our second Signatera webinar on ctDNA testing and molecular residual disease in early-stage colorectal cancer, where we'll explore the important role of ctDNA in detecting a colorectal cancer recurrence. We'll have an in-depth discussion and overview of the Signatera ctDNA test and explore how it can identify cancer recurrence. This webinar is sponsored with an educational grant from Natera and is intended for the information of patients, caregivers, healthcare professionals in conjunction with the launch of the test in Canada by LifeLabs. My name is Barry Stein, and I'm the President and CEO of Colorectal Cancer Canada. I'm also a survivor of early age onset of metastatic colon cancer that was diagnosed in 1995, and I hope to bring some personal perspectives in the question period today. I'm delighted to have the opportunity to moderate this webinar, and I'm confident that you will also find it informative and filled with valuable information. It's with great pleasure to have with us, it is a great pleasure to have with us today two distinguished speakers, Dr. Minetta Liu, who is a medical oncologist and the Chief Medical Officer of Oncology at Natera. Prior to her transition to industry, Dr. Liu served as professor and research chair in the Department of Oncology at the Mayo Clinic in Rochester, Minnesota. In her 10 years at the Mayo Clinic, she held a secondary appointment in the Department of Laboratory Medicine and Pathology and served as co-leader of the Genomics in Action strategic priority for the Center of Individualized Medicine and established the first precision oncology clinic. Dr. Michael Raphael is a medical oncologist at the Odette Cancer Center at Sunnybrook Health Sciences Center. His practice is dedicated to the care of patients with gastrointestinal cancers. He is also an assistant professor at the University of Toronto and head of the GI Medical Oncology Clinical Trials Program and medical oncology lead for the hepatic arterial infusion program at Sunnybrook. Today, Dr. Liu will discuss important information about the Signatera test, including what the test is comprised of, how it works, what the validation studies have been done to date, and how the test can be applied to monitor early stage colorectal cancer. And Dr. Raphael will discuss some individual case studies and provide his perspective as a medical oncologist treating colorectal cancer patients in Canada. Following their presentations, there'll be an opportunity for our speakers to respond to any questions that you may have. If there is insufficient time to answer your questions, our speakers will be pleased to respond to your questions by writing in the days following the webinar. I'm now so pleased to introduce Dr. Minetta Liu.
Thanks very much, Barry.
Thank you.
So I'm going to give an overview of Signatera's molecular residual disease test in colorectal cancer. These are my financial disclosures. I did a fair amount of research and advising when I was in academic practice, and then I joined Natera in June of 2022. Natera has a strong history of product innovations and has really been focused in the cell-free DNA technology space. This started in 2009 with women's health. We didn't foray into oncology until 2017, but only 2 years later, we have a launch for a product in colorectal cancer. Oncology at Natera includes several products. We have over 10 million tests that have been processed to date and 400 more patents issued or pending. We are focused on residual disease detection and the applications in cancer monitoring for early stage disease. ctDNA testing or circulating tumor DNA testing is what we're going to focus on today. Our product is known as Signatera. The reason we developed an assay looking at circulating tumor DNA is because there are limitations in measuring disease burden using current tools. We have imaging, but we can't on imaging detect micrometastatic disease, and it also then exposes patients to radiation. We have routine clinical pathologic characteristics. These are risk features that from the tumor itself or from a patient, but these can also be subjective and don't always correlate with outcomes, meaning survival related to cancer diagnoses. From the blood, we do have serum-based protein biomarkers. Unfortunately, they have low sensitivity and specificity, meaning that they can be hard to detect, not always seen when someone has cancer. And if they are detected, doesn't always mean that cancer is there or progressing. There's been an evolution of tumor surveillance over time, dating from 1896 with the X-ray machine, progressing through a variety of imaging modalities, ultrasound, CT scans, MRI, PET-CT scans, and now circulating tumor DNA. And as you look at this over time, you can see that we're getting more refined in our ability to detect cancer. So 10 to the 9 cancer cells with a routine X-ray, 10 to the 7 cancer cells with CT scans, and now 10 to the 5 cancer cells, at least with current methodologies for circulating tumor DNA detection. And as those technologies improve, that detection will improve as well. So what is circulating tumor DNA, and what are we talking about when we talk about MRD? Cancer cells release circulating tumor DNA into the bloodstream. Either the cells are dying or they're actively pushing DNA and other materials into the blood. ctDNA is a powerful tool that can then be measured to assess the absence or presence of what we call molecular residual disease, meaning detecting that DNA in the bloodstream, even if we might not see evidence of a cancer on an imaging study or on a physical exam. ctDNA is a dynamic, real-time biomarker with a normal half-life of less than 1 hour. And although a blood draw is not non-invasive, it is minimally invasive and does afford us an opportunity to repeat test the blood to see if there are changes in the tumor, unlike having to do biopsies, which certainly are associated with more discomfort and cost for patients. Signatera is a minimal residual disease test or molecular residual disease test. It is a personalized tumor-informed assay which distinguishes itself from other blood-based assays for cancer care. This requires a sample of tumor tissue that's collected as part of routine care, and that tissue is sequenced to identify a unique signature of mutations. Again, this is personalized for the tumor in the individual patient. From that unique signature of tumor mutations, we will custom design a blood test for every patient, targeting the top 16 mutations found in the tumor. So 16 unique features of the tumor then get put into this one single blood test. It's like creating a footprint for that tumor or fingerprint. That blood test then serves as a personalized assay that can be used to test patients' blood for the presence of circulating tumor DNA. And again, this can be done repeatedly over the course of time. This is an example of a Signatera report. So we'll report the presence and absence of ctDNA, positive, negative, but we also can measure circulating tumor DNA as mean tumor molecules per mil of plasma. So that's a quantitation or a way of actually measuring not just is it there or not, but what's happening to it over time. Because of the wealth of data that we've created across many solid tumors, in the United States, Medicare covers testing for colorectal cancer, breast cancer, muscle-invasive bladder cancer, as well as all solid tumors during treatment with immune checkpoint inhibitors or immunotherapy. We can use ctDNA or MRD testing to support treatment decisions. One urgent question is there any cancer left in the body after surgery? If you do a scan, you don't see anything. It's called postoperative residual disease detection. We can use Signatera after surgery, perhaps to evaluate the need for adjuvant therapy. Adjuvant therapy or medications that are given after surgery are really targeting that microscopic disease that we can't see. A second important question is there cancer lurking? So all treatment is done, but did you do what you said you were going to do? Serial monitoring can be performed to rule in or exclude the potential for a recurrence. And with a blood test like Signatera, we can detect recurrences earlier while the tumor may either be resectable or certainly curable. And is the treatment working? Treatment response monitoring can be facilitated by using Signatera to assess tumor response to immunotherapy quantitatively. We're here to focus on colorectal cancer as part of Colon Cancer Awareness Month. Recurrence rates in stage 2 colorectal cancer and stage 3 colorectal cancer are illustrated here. Surgery alone is very effective in both stage 2 and 3 colorectal cancer, 80%, 50% cured by surgery alone, respectively. But not everybody is cured by surgery, and chemotherapy is administered, but not everybody benefits from chemotherapy. And chemotherapy isn't necessary in everyone. So can we use a test to help reduce the number of patients who receive chemotherapy by targeting those patients who truly need chemotherapy? And that's really the purpose of MRD testing right after surgery. A variety of studies have been done, so I'm just going to summarize some of the data from these key clinical trials. This is from the Galaxy clinical trial, which is part of Circulate Japan. This is an observational study where patients undergo surgery for a new diagnosis of colorectal cancer and then have blood drawn and are observed over the course of time. What you're looking at here are survival curves. We're looking at disease-free survival and the percent of disease-free survival over time. The straighter the line in terms of it being horizontal, like the line at the top, better, basically. Looking on your left, you're looking at all stages, stage 2, 3, and resectable stage 4 represented in the Galaxy trial in what we call the MRD window, which is a blood draw about 4 weeks after surgery. And ctDNA positive patients, which are represented in the green line or the top line, did much better than those patients who had ctDNA detected. The same is true if you look at all stages within the surveillance window, which means that surgery is completed, no adjuvant chemotherapy is administered, or a patient has surgery and chemotherapy is administered, all is said and done, and we're basically watching and waiting. Patients who have ctDNA not detected or who are ctDNA negative, again, did much better in terms of disease-free survival than those patients who had ctDNA that was detected. In fact, circulating tumor DNA or ctDNA by Signatera proved to be the strongest prognostic factor for colorectal cancer in the Galaxy trial. So this is looking at disease-free survival based on ctDNA status at that MRD window, meaning after surgery. Here we define that window as 2 to 10 weeks after surgery. The 24-month disease-free survival was 3.8% in the MRD positive group, versus 89.1% in the MRD negative group. That is a very highly statistically significant difference. If you look on the right-hand side, this is looking at multiple variables or characteristics of tumor or of patient that can be associated ultimately with outcomes. And as you can see at the top, ctDNA at the MRD window, if it's positive, is all the way to the right. And showing that it is the strongest prognostic factor for disease-free survival and poorer disease-free survival. Again, we're talking about stages 2 and 3 colorectal cancer where adjuvant chemotherapy is administered or can be administered. And can ctDNA detection help us to define which patients should or should not receive chemotherapy, because we can predict benefit based on that testing. So looking at patients who are ctDNA positive, so all of these patients had detection of circulating tumor DNA right after surgery. Those patients did benefit from chemotherapy. That's represented again in that top line for disease-free survival compared to those patients who did not receive chemotherapy. So patients who are MRD positive post-surgery demonstrated a significant benefit from adjuvant chemotherapy. That's what ACT stands for. This is in contrast to patients who were ctDNA negative, where testing did not reveal molecular or minimal residual disease after surgery. Again, these are stages 2 and 3 patients with colorectal cancer, and those two lines are on top of each other. They all did well. Patients who were MRD negative post-surgery demonstrated no significant benefit from adjuvant chemotherapy. Importantly, we can look at the blood test over time. So it's not just looking at one result right after surgery. So comparing ctDNA detected after surgery versus clear at 6 months, you can see it disappear. That's called clearance. So ctDNA clearance at 6 months, again, showed that patients had much improved disease-free survival over those who did not clear. And importantly, again, as you're checking over the course of time, sometimes the result will go away and come back. Does that mean the same if it goes away at any point in time? Does the fact that it comes back and becomes detected again mean something? And that's what you see on the right-hand side. The top line is sustained clearance, that green line. The blue line showing inferior disease-free survival of those patients who did not clear. And somewhere in the middle is transient clearance, where again, it cleared, it went away, but it did come back again. The Bespoke trial is an observational trial that was supported by Natera, completely different patient population. This was performed in the United States. The results, when we did similar analyses to Galaxy, are virtually identical. We did have the ability to look at some additional data, and this was recently reported, and we were looking at rates of oligometastasis-directed therapy. So in colorectal cancer, what can happen is that new metastases can develop or occur, but these are very limited, very few lesions where maybe without systemic or medical therapy, you can do site-directed therapy, for example, just removing and targeting that lesion or managing it another way. So 101 patients in Bespoke did have a recurrence. Oligometastatic directed therapy was possible in 40 patients. And they actually, half of those patients did well with only oligometastatic directed therapy. And those types of therapy are broken down here in terms of localized treatments. One patient received chemotherapy with radiation. And very importantly, what happens to the patient as you're doing this testing? Are we doing harm, perhaps, by giving results to patients where you might not see something on a scan, or you might see something on a scan? So there have been concerns, understandably, about the potential for fear, anxiety, mood disturbances around the test itself. So as part of Bespoke, we did patient-reported outcomes and questionnaires. We received 1,130 responses from 413 patients. 73% of patients reported that their test results reduced anxiety about cancer recurrence. 87% felt they were receiving the right treatment after receiving results, giving them confidence in what they were doing. 92% would continue to use ctDNA testing to monitor cancer, and 96% valued the additional information received from ctDNA test results. One question is, if you find ctDNA after definitive treatment is completed, you're in that surveillance phase, then what happens if you find a signal in the blood, but the scans don't show anything? So we are now working with many groups to help generate that evidence. It's called Treating on Molecular Recurrence. So the INTERCEPT study is being done at MD Anderson Cancer Center in Houston, Texas. This is looking at patients with stage 2 colorectal cancer, stage 3 colorectal cancer, and resectable stage 4 colorectal cancer, where patients have completed their definitive therapy, are in surveillance, and have ctDNA drawn predominantly during the course of surveillance. If there is a signal in the blood, ctDNA by Signatera is detected or positive, and scans are performed and there's no evidence of disease, they're offered the opportunity to participate in any of a number of MRD clinical trials. Initially, there was, this is an ongoing effort, but as was reported at ASCO, big conference last year, 184 patients, or 61% of the patients who had enrolled, were ctDNA positive during surveillance. About half of those patients had clean scans, and about half of those patients enrolled in clinical trials, showing the power of this sort of a platform. And those clinical trials are being performed and will read out to help us to prove if there is benefit on treating on molecular recurrence. So in conclusion, how can Signatera help patient care? Again, there are a number of questions. Does Signatera reliably predict for cancer recurrence? Yes, we have a wealth of data to support its prognostic ability. Does Signatera reliably predict treatment outcomes? Yes. As we saw, patients who are MRD positive will benefit from adjuvant chemotherapy, whereas patients who are MRD negative do not benefit from chemotherapy. Can clinicians use early changes in Signatera to predict long-term outcomes? Yes, we've seen that early ctDNA clearance on adjuvant chemotherapy correlates with disease-free survival. Is Signatera useful in oligometastatic stage 4 colorectal cancer? Yes, in helping to direct patients toward oligometastatic directed therapy. How do patients view MRD testing? Is it causing increased anxiety? Gratefully, in the Bespoke study, we saw that no significant difference in anxiety was seen between Signatera positive and negative patients. Signatera turned positive during surveillance. Now, what do we do? About 50% of the time, you will find radiographic or radiologic evidence of disease, but if the scans are clear, one could consider intensifying surveillance and/or enrolling those patients into clinical trials. It's been a pleasure talking to you today. I just want to give a word about Signatera and its availability in Canada. It became available as a send-out private pay test through Life Labs Genetics on February 1st of last year. Payment and generation of a test requisition form are completed directly through the Life Labs website. They provide the kits. They'll help get the tissue sample that's required to develop the test. We'll send all of the samples to Natera. The cost is $4,500 for the initial test and $2,000 for the subsequent blood tests. The blood test results are available in 4 to 6 weeks for the first blood test because we need the time to develop the test first. Once that test is locked down, it takes 1 to 2 weeks for subsequent tests. It's now my pleasure to introduce Dr. Michael Raphael, who's going to give his clinical insights about ctDNA testing. Thanks again.
It is my sincere pleasure to be with you all today on this webinar put on by Colorectal Cancer Canada, and thank you to Barry and Minetta for those really insightful introductions and talks. I am a medical oncologist at the Odette Cancer Center, and I'm here today to give you a bit of clinical perspective about how using the Signatera tumor-informed circulating tumor DNA can help bring some personalized cancer care to patients and families. So I have no conflicts of interest or financial disclosures to make. And so my objectives over the next 15 minutes or so are to review the potential roles of tumor-informed circulating tumor DNA to help personalize care for patients with early and late-stage colorectal cancer, to present some case examples where circulating tumor DNA using Signatera was very helpful for myself and my patients, and ask you to advocate for reduced cost and broader access to this very important tool that I think all patients in Canada who are undergoing treatment for colorectal cancer should have access to. I'll give you some background and context. Now, Minetta gave you some really detailed information on the Signatera assay and some of the studies that have been done to date. I'm going to give you a little bit of background from the clinical context when I'm seeing a patient in clinic, why this test can be particularly helpful. So starting off with localized colon cancer, talking about stage 2 and stage 3 disease, surgery is the mainstay of treatment for stage 2 and stage 3 colon cancer. Following surgery, adjuvant chemotherapy may be recommended to try to kill off any residual cancer cells to reduce the chance of cancer recurrence. But even in 2024, we have no 100% accurate way to predict if the patient sitting in front of us will recur after their operation. As you just heard, even with CT scans, PET scans, MRIs, if they don't show visible cancer, it unfortunately does not mean that there is no residual cancer at all. Cancerous cells may be present beneath the limit of modern imaging threshold detection. You have to remember that each cancer cell by itself is tiny. They're about 20 micrometers in diameter. By the time a lesion is 0.5 centimeters, about the limit of where we can start to detect things on CT scans, that lesion already has about 10 million cancer cells. So if there's 1,000 or 10,000 or even 100,000 cancer cells hiding in the body, they will have not reached that critical mass to allow a lesion to be seen on imaging. Because we cannot be certain if residual cancer exists after surgery, we are now using several tools to help us make a recommendation about whether to pursue adjuvant chemotherapy or not. Some of these tools might include looking at risk factors, using risk calculators, or looking at historical outcomes of similar patients with a similar type of cancer pathology. So, for example, in stage 2 disease, we'll look at the patient's pathology and ask, does it show any features which should make this a high-risk stage 2 colon cancer? Those would be things like, is this a T4 tumor? Were there less than 12 lymph nodes sampled? Was it high grade? Was it poorly differentiated? We'll also look at clinical features of the case. Did the patient present with a perforated tumor? Did the patient present with an obstructing tumor? And by looking at the presence or absence of these risk factors, we'll try to get a sense of how likely it is that this cancer could come back in the future, and how likely it is that this patient may benefit from the use of adjuvant chemotherapy. As an extension of these risk factors, now these risk calculators that are widely available, There are many different sites that will offer this. This particular one is from Memorial Sloan Kettering Cancer Center. You can go onto their website. You can plug in all the information from the previous slide, the T stage of the tumor, the N stage of the tumor, the grade of the tumor, and it will generate an expected overall survival after surgery. And this can help in the discussion between a patient and their oncologist about whether or not it makes sense to pursue adjuvant chemotherapy. When we move into the stage 3 setting, most oncologists would recommend adjuvant chemotherapy for most patients with stage 3 colorectal cancer because unfortunately the chance of recurrence is quite high. In order to determine how much benefit a patient might get from adjuvant chemotherapy and how much benefit they may get from each of the respective components of the treatment, what we do is we look at you as the patient, your pathology, and then we look back in time to see how did similar types of patients with similar pathologies do when they received adjuvant chemotherapy. And so this graph here is an example I use in clinic all the time for patients with stage 3 cancer. This comes from a large international collaboration, which was called the IDEA trial, which was 6 independently run clinical trials around the world that mostly included patients with stage 3 colorectal cancer. At the bottom of the screen, you can see the distribution of subgroups within the stage 3 diagnosis. So the T stands for T stage, so that's the tumor depth. The N stands for N stage, which refers to the number of lymph nodes that were positive. On the left-hand side of the screen, you can see low T and low N. On the right-hand side of the screen, you see high T and high N. What you can see in the shaded bars with the diagonal lines is the chance of being alive and well without cancer following surgery alone. Understandably, that chance is highest when you're starting off with a low T and low N stage. In the dark gray bar, you can see the added benefit of taking the fluoropyrimidine component of your chemotherapy. That's either that capecitabine pill or the fluorouracil bottle. In the white bar, there's the added benefit of the first 3 months of the oxaliplatin IV chemotherapy. And in the black bar, there's the added benefit of the next 3 months of oxaliplatin IV chemotherapy. So the treatment given between 3 and 6 months. And so using figures like this, we try to have discussions with patients and their families about how much the relative benefits of chemotherapy might be given their T and N stage. But what you can recognize is that these tools tell you about the average risk of recurrence for someone who shares your risk factors. These tools tell you nothing about your actual risk of recurrence and whether chemotherapy will benefit you or not. Moreover, our current staging systems have significant limitations, and I'll point your attention again to these 2 figures. One would reasonably assume that if you have a lower stage cancer, a stage 2 cancer, the chance of the cancer coming back would be less than if you had a higher stage cancer, a stage 3 cancer. After all, a stage 3 cancer had cancer cells which were able to sneak out in the lymph nodes. But as you can see on this figure, that is not always true. Starting on the left-hand side of the screen, we can see that for someone with a stage 2 cancer, that's a T4BN0, their chance of survival after surgery alone is about 71%. And you can see that on the right-hand side of the screen, that patients with certain subgroups of stage 3 cancer actually have better overall survival compared to patients with a stage 2 cancer. So a T1N1A has 80%, T2N1A has 77%, and so on. All better than the 71% associated with a stage 2 cancer. And this is an extremely important point to acknowledge because the stage of the cancer is the biggest factor that determines whether or not adjuvant chemotherapy is recommended. For most patients with stage 2 cancer, we generally have not recommended adjuvant chemotherapy. For most patients with stage 3 cancer, we generally do recommend adjuvant chemotherapy. And so it's a hope among all of us that the future, instead of just being stage 1, 2, or 3 cancer, it could be stage 1, 2, or 3 plus or minus whether they have positive circulating tumor DNA. And it could be the future that rather than recommending chemotherapy based off of potential risk factors for patients who aren't actually you, that we could recommend adjuvant chemotherapy on the basis of whether or not the circulating tumor DNA is positive, or even hopefully omit chemotherapy when the circulating tumor DNA is negative. So the conclusion to this background section before we jump into some cases is that, in my opinion, circulating tumor DNA is the best tool available in 2024 to help determine the risk of cancer recurrence following surgery for stage 2 and stage 3 colon cancer. In my opinion, this is the best tool available in 2024 to help you decide if you should undergo chemotherapy for a stage 2 cancer and possibly for a stage 3 cancer, although we still remain to see some evidence on this. And in the next 15 minutes, I'm going to show you some cases where this has been particularly helpful for my patients and I. So jumping into the cases, I'll just say that the demographics and the details of all these cases have been altered to protect patient confidentiality, but the heart of what happened in the encounter remains, and the importance of using the Signatera assay is honest and truthful here. So starting off with a case of stage 2 colon cancer, I'll show you an example of where Signatera helped to inform and reinforce decision-making. So this is a patient of mine who was 20 years old and presented with bright red blood per rectum. This patient was found to have a sigmoid cancer and underwent a sigmoid resection. The pathology showed that this was a stage 2 cancer. It was a T3N0 tumor. And very importantly, this tumor had deficient mismatch repair proteins. In other words, this was an MSI high tumor. And why that's important is because we know that there's very strong evidence that patients who have MSI high stage 2 cancers generally do not derive any benefit from adjuvant chemotherapy because their prognoses are already so excellent. The finding of a deficient MMR or MSI high status in stage 2 cancer is the most important factor to tell us we should not recommend adjuvant chemotherapy to this patient. We then go look through the other potential factors in the pathology to look for any features that could be interpreted as being high risk. And highlighted in red here, you can see that this patient did have one high risk factor, which is that there was LVI, which is lymphovascular invasion. However, on balance, because this patient has a stage 2 cancer, because it is deficient in the mismatch repair proteins, according to all international clinical practice guidelines, it would be recommended that this patient not be offered adjuvant chemotherapy because their prognosis is already so excellent that it is extraordinarily unlikely that adjuvant chemotherapy could provide any meaningful benefit. So I recommended no adjuvant chemotherapy, and the patient and her family agreed. But as you can imagine, this is a 20-year-old patient. She and her family were very anxious about the diagnosis of colon cancer, as anyone would be, and they wanted to gather as much information as possible to help them know, was it the right decision to not take chemotherapy? So we talked about the Signatera tumor assay, and lo and behold, her post-op Signatera assay was negative. And this provided reassurance to both the patient, her family, and frankly myself, that we were making the right decisions. We were using the guidelines, which is still very important. We're using all the available clinical information, which remains incredibly important. And this was just an added, very powerful tool to help us be even more reassured about our decision. So moving into another case of stage 2 colon cancer, I'm going to show you another instance where this helped reassure the patient and myself as the oncologist, although it didn't necessarily impact treatment decision making. So this was a case of a 40-year-old gentleman who presented with abdominal pain. They were found to have a transverse colon cancer and they underwent a colectomy. Like the previous patient, they were also found to have a stage 2 colon cancer, a T3N0. And like the previous patient, they also had LVI present, that lymphovascular invasion, which makes this a quote-unquote high-risk stage 2 colon cancer. Unlike the other patient, this was a microsatellite stable tumor, so it did not have that MSI high status. Even so, with just the presence of one high risk feature for stage 2 colon cancer, most oncologists around the world would not recommend adjuvant chemotherapy because in this setting, there is actually no good evidence that using chemotherapy provides a significant survival advantage. So I had an informed discussion with the patient. I used some of the previously discussed tools, and I said, we could use chemotherapy, but it wouldn't be my recommendation because I do not think that it would materially increase the chance of survival. However, No decision on oncology should be based just off of what the oncologist recommends. It needs to be about a discussion back and forth and take into consideration the patient's values and preferences and their fears and their hopes. And the patient was very educated and was very clearly able to say, I understand what you're saying. I understand that the chemotherapy does not have a lot of evidence, but if this cancer were to come back, I'll never forgive myself for not doing chemotherapy, even if it would just have a tiny, tiny, tiny benefit. And I'm willing to take the risks of chemotherapy in that regard. And so the patient made an informed decision, and I was very much happy to support it. We talked about using Signatera, and again, the patient was very clear that regardless of the result, it wouldn't change his mind, but he was very keen to do it, again, for the added information that it could provide to help alleviate any anxiety and any worry. So the patient at baseline did go ahead and have Signatera done. Thankfully, at baseline, it was negative. And although it's a bit grainy in this picture, you can see that once again, after the patient finished his adjuvant chemotherapy, we repeated the Signatera and it was once again negative. So in this case, the Signatera didn't change the treatment decision-making process for the patient. The patient's mind was already set, but it helped inform the patient and myself and reassure and provide us further immediate reassurance that this patient was very likely to have an excellent outcome and have a very low chance of cancer recurrence. And I think that's a very meaningful result in and of itself. Moving on to stage 3 colon cancer, we're going to show how a case of where Signatera helped to ensure clearance of that minimal molecular residual disease, the MRD, that you heard about. So this again was another 40-year-old patient of mine who presented with abdominal pain, found to have a transverse colon cancer, underwent a subtotal colectomy. Their pathology showed a stage 3 colon cancer. The lymph nodes were positive, making this a stage 3, so it was an N1B tumor. And my recommendation was to start adjuvant chemotherapy as per all international guidelines, and the patient agreed. And so we discussed as well about the use of adding Signatera to see if it could provide us with some more information. But this was not going to alter our decision to start on the 3 months of adjuvant chemotherapy. So we did draw the first Signatera test post-operatively. And again, it's grainy here, but you can see on the Signatera figures when it's a colored in black circle, that means it's positive. So this patient had a positive Signatera test post-op, which is really interesting because the CT scans, the blood work, including the CEA, all were negative. The only thing that suggested that there could be some residual cancer cells was the Signatera test. The patient completed their 3 months of adjuvant CAPE-BOX chemotherapy, and we repeated the Signatera test, and thankfully it was negative after the fact. So going back to what you heard previously, this patient had clearance of the Signatera test, and so this portends a much, much better prognosis. And another really helpful thing about this is many of you in the audience maybe previously have received adjuvant chemotherapy with your oncologist, and at the end of it, you're done, and you say, well, how do we know if it works? And the doctor has no good way to tell you, and we have to say, and I've had to say this myself many times, unfortunately, the only way we're going to know if it works is if the cancer doesn't come back in 5 years, which is a very unsatisfying thing to say as an oncologist and an even more unsatisfying thing to hear as a patient. For a patient, if you can be told, listen, the Signatera test was negative, it was positive, we did our chemotherapy, now it's negative, that's real-time actionable information that all that trouble and the pain that you went through for 3 months was actually worth it for something. So I think that's a huge positive of this test. And finally, moving to the stage 4 setting. So in stage 4, advanced disease, the mainstay of treatment are palliative systemic therapies such as chemotherapy, targeted therapy, and immunotherapy. These therapies aim to improve how long and how well our patients live. Now, as part of that, because when we have advanced disease, unfortunately, most patients are not cured of their cancer, treatment breaks are an important part of the treatment strategy to allow patients to spend meaningful time away from the cancer center and to regain their quality of life. And tumor-informed circulating tumor DNA may be helpful to inform treatment decision-making in this setting. So let's talk about a case where Signatera helped one of my patients and determining when to take a treatment break. So this was a 65-year-old patient who was diagnosed with a left-sided colon cancer who had disease metastatic throughout the liver. They started treatment with first-line FOLFIRI and panitumab with an initial good response in the liver, but not enough to allow curative intent surgery. They therefore enrolled in our hepatic arterial infusion pump program at Sunnybrook. Shout out for anyone who is interested. We're always keen to meet more patients and to work together to improve outcomes. They underwent a low anterior resection and had implantation of the hepatic arterial infusion device. They were treated with this special type of chemotherapy we use through the hepatic arterial infusion pump called FUDR, along with their systemic FOLFIRI and their panitumab. They then had follow-up CT scans about 6 months after therapy, which showed that most of the liver lesions were gone. There were a few liver lesions that were remaining, but it was indeterminate if these just represented scar tissue or there was active residual disease. The patient went on to have a PET scan, and PETs have lots of limitations that we don't have time to address today. But within those limitations, there was no evidence of metabolically active disease. And so we discussed this might be a good opportunity to go after the Signatera assay to see if there was any molecularly detectable residual disease. And very interestingly, when we did this patient's assay, it was negative for Signatera. So there was no residual detectable disease. So how do we interpret this? Well, in the absolute best case scenario, it would be that the patient's cancer had been completely eradicated by the hepatic arterial infusion pump in combination with systemic therapy, and they could hopefully be cured of their cancer. That is an outcome that we have seen in patients on our hepatic arterial infusion pump program. The second best outcome would be that we've just killed so many cancer cells that we've brought the tumor level down to a point where it can no longer be detected by this very sensitive assay, which again is a very good prognostic sign, and hopefully it would mean that it would be a very long time before this cancer would come back and a very long time before this patient would need to go back on treatments again in the future. So both good outcomes. So in conclusion, tumor-informed circulating tumor DNA is an important tool in the management of colorectal cancer. Tumor-informed circulating tumor DNA can help facilitate shared decision-making between the oncologist and their patients, help patients feel more confident in their treatment choices, help us understand whether our treatments have been effective or not, and help guide how to adapt, time, and change our treatments. Right now, cost is the major barrier for most, and as I mentioned at the outset, I'm hoping we can bring down the cost and bring up the accessibility. And with that, I will thank you for your kind attention. It has been my sincere pleasure, and I'm very happy to take any questions, and I will hand it back to Barry.
Well, thank you very much. To both of you, I'd like to thank both our panelists, Dr. Liu and Dr. Raphael, for your very informative presentations, and especially for providing us with the latest of data on the test and providing a better understanding of the usefulness of the test in the context of shared decision-making with patients. I really enjoyed that part especially. Before jumping into the question period, if anyone would like to have additional information on the Signatera test, please scan the QR code that will be posted at the end of the webinar, or go to natera.com, that's natera.com/Signatera-CRC, that's Signatera-CRC. I'm sure you'll find it if you just go to natera.com as well. If the test is appropriate for you, it can be ordered through LifeLabs in Canada, and for Ontario and BC residents, Signatera can be ordered online from the website at lifelabsgenetics.com. For non-Ontario or British Columbia residents, Signatera can be ordered by calling 1-844-363-4357 or by emailing ask.genetics@lifelabs.com, and we'll provide that information again at the end of the webinar. So for now, let's take some of your questions. Very nice activity on the Q&A, and I tried to group some of the questions together so we can try to get it in with the next 10 minutes that we have. So thank you everyone for taking the time not only to be here, but to actually post your questions. I see one more. Hopefully we'll get the last question in as well. I'll do my best to cover as many as I can during this period of time, and if not, feel free to email us afterwards. So a couple of questions had to do with the subsequent testing and who should be tested. So, Dr. Liu or Dr. Raphael, how many subsequent or serial tests should be carried out for a patient, and over what period of time?
I might defer to Dr. Raphael just as our star clinician.
Yeah, it's an excellent question, and it's one that there's not an exact right answer to, because it depends on each patient's individual circumstances. As mentioned before, another factor to consider is cost. So this is not something like the CEA or CT scans that is covered by the government, and patients need to either be able to afford it or to have a really good insurance plan to cover it. So those are some of the limiting factors. In general, in my practice, I find that the Signatera assay provides the most amount of useful information immediately in the post-operative period. So finding out that the Signatera assay is negative, and the study seemed to suggest that if it's negative at 2 time points, that provides the strongest information for prognosis about no chance of the cancer returning, essentially. So in my practice, I'm really using Signatera mostly for stage 2 colon cancer. And so we're using it in the post-operative setting and in the stage 3 setting with the appropriate counseling that we don't yet have all the information. I think it's helpful if you can get it before and after the chemotherapy. In the stage 4 setting, its use is much more limited, at least as it's currently used. There are some settings where I'd be excited to use it. For example, in patients who have colorectal cancer liver metastases that are resected, and we want to know, do they have any residual disease and should they have any further adjuvant chemotherapy or not? And as in the example that I gave you, when the patient is considering taking a treatment holiday, if we can show that there's been a reduction in the Signatera by a significant fraction, because as Dr. Liu had mentioned in her talk, it's not just positive or negative, but there's actual quantification, that can help provide additional information that if there's been a significant reduction, perhaps it'll be a very long time before you need to restart back on your chemotherapy again.
That's great. So a little bit of a few more specific questions just came in as well, but I'm going to take that last one a little bit because it's quite an unusual situation. Most of the time we think of doing the test following surgery, in other words, in the adjuvant setting. What about if somebody just didn't have their tumor removed, but just underwent chemoradiation? Would the test still be used in that circumstance? Oops, I lost my sound.
So,
oh, there you go. Okay.
So yeah, so I'll talk and then ask Dr. Liu if she has any thoughts. So if I'm understanding the question correctly, it's someone who has, for example, like a rectal cancer and they're treated with chemoradiotherapy. This is actually an exciting area where circulating tumor DNA assays like Signatera can provide a lot of information. So I don't know the specifics, obviously, of the case, but for example, if we're treating someone now with rectal cancer and they achieve a complete clinical response, which is you cannot see the tumor on CT scan, MRI, or endoscopy, we're now entering a period where we're offering non-operative management and watch and wait. And so rather than putting patients through large rectal cancer surgeries that can have debilitating effects on their quality of life, we're watching them. And this is an area where circulating tumor DNA is really the most sensitive assay we have for detecting minimal residual disease, can be super helpful. Because if it's negative and you have all those clinical factors that are negative as well, I think it's extremely unlikely that the cancer is going to come back. So that's a sort of situation where I would say, yes, if I'm interpreting correctly, Signatera and like assays can be used in someone who's received chemoradiotherapy but not have surgery.
Great. So
Yeah, essentially
go ahead, Dr.
I was just going to add circulating tumor DNA, certainly as we test it with Signatera, is reflective not just of the tumor where it started, but the potential for seeds of that tumor wherever they may be. Certainly there have been many circumstances where patients have not had surgery for whatever reason, and it can still be a good benchmark to understand if treatment has been effective.
A couple of questions on sample collection. So somebody had insufficient sample that was collected, so that could not be used, and they were able to go back just under 2 years previous to get their sample from a colonoscopy. Would that sample be, if it was sufficient in volume, would it be sufficiently fresh, so to speak, in order to use for the test?
Yeah, I think it's a two-pronged question. So one, we can use stored material for several years. So 2 years is certainly well within that framework. Because of the way tissue is preserved, it stays good, so to speak, for a long time. I think the other is if a biopsy versus a surgical specimen, and even if it's representative of the same tumor but from two different sites, is that something where we can still build a reliable test? And the way our algorithms select the variants or the targets to follow in the blood is representative of the tumor sort of as its beginning and something that should persist in that tumor no matter where it goes. So it's very unique for a specific tumor itself, but biopsies of that same tumor from different places can in fact still be representative.
That's great. And here's another one concerning samples. So somebody had their blood and tissue sample done previously by either internally in the hospital or otherwise. And they would like to know two questions. One, and I guess this would be for Dr. Raphael, the first part, can they access their data from it? And secondly, can Signatera or Life Labs in this case access that data that's already stored there for a previous reason and use it for the purposes of the Signatera test?
From a clinical perspective, I can tell you in all the cases where I've done this test, the patients have gotten results first. So Life Labs has an online portal and you get a notification when a new lab has come back. So my patients have all received the result for me because currently it goes to the clinician via fax, which is a bit slower. So the patients who do this test all have access to the results, so they see it in real time as the clinicians do.
Okay. And Dr. Liu, in terms of using previous samples from other tests, can that still be accessed by yourselves? I guess it would have to be stored at the hospital, assuming.
So, I mean, we can use tumor tissue again that's been stored. Blood for the clinical test has to be freshly drawn so that we can process it immediately to develop to generate a reliable result. If the testing was done by another company or internally, we cannot import that information to create the test for an individual.
Thank you. So here's one that's a little bit specific. They would like to know if other tests had missed metastases to their lungs, would the Signatera perhaps pick that up? In other words, lung mets in particular.
It's certainly possible. I think different tests pick up differently. So with Signatera, there have been patients who had lung metastases and the test was negative. You have to remember that there are many factors that go into the ability to detect the DNA in the bloodstream, and one is the blood supply to a tumor. The other is how fast a tumor might be growing. So one could argue you don't need or want to find every single lesion. You need to find the clinically significant lesions. And they're also, with the test, we need to do improvements to improve sensitivity of detection. There's going to be a level, though, where, again, you don't want to detect even though there is something there. And that's the fine line that we're all trying to identify now. Hopefully I answered the question.
Thank you. So here's one that's a little bit complicated, but I'm going to try to simplify it and say, is there any benefit for ctDNA for stage 1 cases?
So the answer is yes and no. So as I mentioned in my slides, there may be an era, hopefully in the not too distant future, when the staging system as we know it is refined, because stage has all sorts of limitations as I presented. So if someone had a stage 1 cancer that was positive for circulating tumor DNA, I would think that that patient, and I don't have the evidence to support this, but I would suspect that that patient has just as high a chance of the cancer coming back as someone with a more advanced stage. And in fact, I would be more worried about a stage 1 patient with positive circulating tumor DNA than it would be about a stage 2 patient with negative circulating tumor DNA when we're talking about the tumor-informed assays. whether or not it should be done really reflects on what's the risk of the cancer coming back. If you look at all stage 1 cancers as a group, the risk of the cancer coming back is incredibly low. I've never seen a stage 1 patient in my medical oncology practice because there's no need to. They never would get chemotherapy. And so I think the answer for right now is that it's not something I would recommend outside of a clinical trial setting where more information can be collected and gathered so that we can inform patients and future patients as well.
I'm going to take one more minute to try to get a couple of more questions in because we want to make sure that we answer as many as possible. Here's, I think, a pretty quick one. Are hemorrhoids predictive of colorectal cancer?
No, none.
Okay, another quick question. From the point of view of funding, we had a few questions with respect to the funding, and we did see the cost of the funding on the previous slide, and the cost of it, or the cost of $4,500, I should say, for the Life Labs test, and the subsequent cost of $2,000 for subsequent tests. Is there anything being done, or do you foresee anything being done either on the public funding side or on the private insurance side in order to alleviate this burden, or any other ways, patient support programs or otherwise?
So
I guess that would be for Dr. Liu or yourself.
So I tell you from the Ontario perspective, probably 25% of the times I've done the Signatera say it's been covered by insurance. So it's variable. Other times patients have had to pay out of pocket. It depends on your plan and what the criteria are for coverage. I think that as there's more information being garnered, I think that there's an increased likelihood that more insurance companies will cover it. It has Medicare coverage in the United States for many different conditions, and that usually is something that insurance companies will look at in Canada and provide coverage for. Whether it's covered at a provincial or a national level is a much more difficult question. And in order for that to be done, you're going to probably have to demonstrate overall survival benefits or, cost benefits in terms of avoiding chemotherapy, avoiding hospitalizations and that sort of thing. So I think the government covering this is at least a few years away, but insurance companies hopefully not that far.
Yeah, I wish I could ask more questions. There's a few other ones that came in. We'll try to answer them in writing post-webinar, and I do want to respect everybody's time. So first of all, thank you so much, Dr. Liu and Dr. Raphael, for such insightful comments and really for taking the time to answer these very detailed questions. I also want to thank, of course, all our viewers today. We had almost 100, and we have about 250 registrants who want to see it on our YouTube channel. So that will be available to answer that question as well post webinar. So probably just give us a day or two to get it up there, and you'll be able to review the entire webinar. I want to thank sincerely our sponsor, Signatera, for giving us this opportunity, and not only to have the test in Canada, of course, but to do this webinar and inform our patients and clinicians. And we look forward to further collaborations and to answering any other questions that you as viewers or other patients or clinicians may have in the future. And we will send them along to both Life Labs and to Signatera, as the case may be. As you can see, it popped up on my screen, or say in our language, say it pooped up on our screen, a little questionnaire. So if you don't mind answering that, if you're unable to do that today, you'll get an email. We'd ask you to complete that for quality assurance on our part. And finally, I just want to thank you all for following us, and for further information, don't hesitate to go to our website at colorectalcancercanada.com or to reach us at info@colorectalcancercanada.com. Thank you, everybody, once again, and we look forward to seeing you soon.